So today's topic is on chronic kidney disease. Chronic kidney disease is a progressive, irreversible loss of kidney function that does not recover. When the kidney function is too poor to sustain life and when the GFR is less than 15 ml per minute, CKD is known as end-stage kidney disease. And at this point, renal replacement is required to maintain life. There are different stages of chronic kidney disease, stages 1 through 5. Because the kidneys are highly adaptive, kidney disease is often not recognized until there has been considerable loss of nephrons, at least 50% of them. The kidneys lose function in an organized fashion involving the 5 stages based on the estimated GFR. Progression towards end-stage kidney disease usually starts with a gradual decrease in GFR. In the first stage, the person may have a normal GFR, that's more than 90 mL per minute, with normal kidney function and no obvious kidney disease. This is because the unaffected nephrons hypertrophy and overwork to compensate for the diseased nephrons. In the next stage, mild CKD, GFR is reduced, ranging between 60 and 89 mL per minute. Nephron damage has occurred and there may be slight increase in the metabolic waste in the blood because there are not enough healthy nephrons to compensate completely for the damaged nephrons. In moderate CKD, GFR reduction continues and ranges between 30 and 59 mL per minute. Nephron damage has continued and the remaining nephrons are not able to manage the kidney functions and there is definite changes in the kidney function. In the fourth stage of severe CKD, there is excessive amounts of urea and creatinine buildup in the blood and in the end stage kidney disease, the kidneys cannot maintain homeostasis and there is severe fluid and electrolyte imbalances and acid-base imbalances also occur. Causes and incidence of end-stage kidney disease. The incidence is high among African Americans and Native Americans. The leading cause for end-stage kidney disease are diabetes and hypertension. Other causes are glomerulonephritis, interstitial nephritis, polycystic kidney disease, prolonged obstruction of urinary tract, vesicoureteral reflux, and pyelonephritis. Clinical manifestations. As kidney function deteriorates, every body system becomes affected. The clinical manifestations are a result of retained substances, including urea, creatinine, phenols, hormones, electrolytes, and water. Uremia is a syndrome in which kidney function declines to the point that symptoms may develop in multiple body systems. It often occurs when the GFR is 10 ml per minute or less. This is a visual of the possible clinical manifestations that can occur with chronic kidney disease. There are psychological manifestations, cardiovascular, gastrointestinal, endocrine, reproductive, metabolic, hematologic, neurologic, ocular, pulmonary, integumentary, muscular, skeletal, and peripheral neuropathy. Clinical manifestations with urinary system. Because most people continue to have sufficient urine output, it is often difficult to convince patients that they have kidney disease. As CKD progresses, the ability to produce dilute urine is reduced, resulting in a urine with fixed osmolality or isothenuria, and reduced urine output or oliguria and fluid retention. Inability of the kidneys to concentrate urine results in the specific gravity to be fixed around 1.010. Anuria is less than 40 ml urine output per day. Metabolic disturbances. As GFR decreases, BUN and serum creatinine levels increase. BUN level increases not only from kidney failure but also from protein intake, fever, corticosteroids, and catabolism. Significant increases in BUN results in nausea, vomiting, lethargy, fatigue, impaired thought processes, and headaches. Altered carbohydrate metabolism. Defective carbohydrate metabolism is caused by impaired glucose metabolism resulting from cellular insensitivity to the normal action of insulin. Mild to moderate hyperglycemia and hyperinsulinemia may occur. Elevated triglycerides. Elevated glucose levels lead to increased insulin levels, and the increased insulin stimulates hepatic production of triglycerides. Insulin is excreted by the kidneys, and therefore, in chronic kidney disease, insulin remains in circulation longer. Almost all patients with uremia develop dyslipidemia with elevated levels of very low density lipoproteins, normal or decreased levels of low density lipoproteins, and decreased levels of high density lipoproteins. Or, in other words, decreased levels of the good lipoprotein. Electrolyte and acid imbalances. Hyperkalemia results from the decreased excretion of potassium by the kidneys, the breakdown of cellular protein, bleeding, and metabolic acidosis. Potassium may also come from the food consumed, dietary supplements, drugs, and IV infusions. Fatal dysrhythmias can occur when the serum potassium level reaches 7 to 8 MEQs per liter. Sodium levels may be elevated, normal, or low in kidney failure. Early in CKD, hyponatremia is common because there are very few healthy nephrons to reabsorb sodium, and so sodium is lost in urine. In the later stages, however, kidney excretion of sodium is reduced as urine production decreases and hypernatremia results. This also results in hypertension and edema. Calcium and phosphate alterations also occurs. The kidney produces calcitriol, which is the active form of vitamin D, which then enhances intestinal absorption of calcium. Absent or insufficient vitamin D prevents absorption of calcium, thus causing hypocalcemia. Excess phosphates are excreted by the kidneys normally but is reduced in CKD, resulting in hyperphosphatemia. This results in hypocalcemia. Hypocalcemia stimulates the parathyroid gland to release parathyroid hormone, and calcium is released from the bones, resulting in bone density loss. Magnesium is primarily excreted by the kidneys. Hypermagnesemia is generally not a problem unless the patient is ingesting magnesium, like milk of magnesia, magnesium citrate, and antacids containing magnesium. Clinical manifestations of hypermagnesemia can include absence of reflexes, decreased mental status, cardiac dysrhythmias, hypotension, and respiratory failure. Metabolic acidosis results from the inability of the kidneys to excrete acid, primarily ammonia, and from ineffective reabsorption or regeneration of bicarbonates. This leads up to a buildup of hydrogen ions, causing acidosis. Hyperkalemia also contributes to acidosis. In CKD, the plasma bicarbonate level, an indirect measure of acidosis, stays at around 16 to 20 MEQs per liter because the hydrogen ion production is usually balanced by buffering from the demineralization of bones, which is the phosphate buffering system. Clinical manifestations of the hematological system includes anemia and bleeding tendencies. Infection is also seen with leukocytosis. Cardiovascular system. The most common cause of death in patients with CKD is cardiovascular disease. Myocardial infarction, ischemic heart disease, peripheral arterial disease, heart failure, cardiomyopathy, and stroke are leading causes of death. Even a slight reduction in GFR has been associated with a higher risk for development of coronary artery disease. Traditional cardiovascular risk factors are common in CKD patients, such as hypertension and elevated lipids. However, much of this cardiovascular disease may relate to non-traditional cardiovascular risk factors, such as vascular calcification and arterial stiffness. Hypertension is aggravated by both sodium retention and increased extracellular fluid volume. Increased renin production may also lead to hypertension. Long-standing hypertension, extracellular fluid volume, or extracellular fluid overload and anemia contribute to development of left ventricular hypertrophy, which can eventually result in cardiomyopathy and heart failure. Patients with CKD are susceptible to cardiac dysrhythmias related to hyperkalemia and decreased coronary artery perfusion. Uremic pericarditis can develop and can occasionally progress to pericardial effusion and cardiac tamponade. Pericarditis is typically manifested by a friction rub chest pain and low-grade fever. With low-grade fever. Respiratory system. With severe acidosis, the respiratory system may attempt to compensate with Kussmaul's respiration, which is indicated by increased rate and depth, which results in increased carbon dioxide removal by exhalation through the lungs. But on the contrary, if there is too much carbon dioxide which is blown off, respiratory alkalosis can result. Dyspnea may occur as a manifestation of fluid overload, pulmonary edema, uremic pleuritis, pleural effusion, and respiratory infections like pneumonia. GI system. Uremia affects the entire GI system. The flora of the mouth changes with uremia. The mouth contains the enzyme urease, which breaks down urea into ammonia. The ammonia generated causes stomatitis with exudates and ulcerations, a metallic taste in the mouth, and uremic fever, which is a urinous odor of the breath, which are commonly found in CKD. Anorexia, nausea, and vomiting may develop if CKD progresses to end stage and is not treated with dialysis. Weight loss and malnutrition may also occur. GI bleeding is also a risk because of mucosal irritation and the platelet defect and ulcer formation in the mouth and peptic ulcer. Constipation may be due to the ingestion of iron salts and or calcium-containing phosphate binders. Constipation can be made worse by limitations on fluid intake and physical activity. Integumentary system. The cause of pruritus is multifactorial, that is dry skin, calcium phosphate deposition in the skin, and sensory neuropathy. The itching may be so intense that it can lead to bleeding or infection secondary to scratching. Uremic frost is an extremely rare condition in which urea crystallizes on the skin and is usually seen only when the bun levels are extremely elevated. Never use soap on patients with chronic kidney disease with uremia because of the extreme dryness caused by soap. Neurological system. As a result of kidney failure, there is increased nitrogenous waste products, electrolyte imbalances, metabolic acidosis, atrophy, and demyelination of nerve fibers. The central nervous system becomes depressed, resulting in lethargy, apathy, decreased ability to concentrate, fatigue, irritability, and altered mental ability. Seizures and coma may result from a rapidly increasing bun level and hypertensive encephalopathy. Peripheral neuropathy is initially manifested by slowing of nerve conduction to the extremities. With advanced stage 5 renal failure, there is complaints of restless leg syndrome, which may be described as burning sensation in the legs and feet. Eventually, motor involvement can lead to foot drop, muscular weakness and atrophy, and loss of deep tendon reflexes. Muscle twitching, jerking, hysterexis or hand flapping tremors, and nocturnal leg cramps can also occur. With low serum calcium levels, parathyroid hormone stimulates the release of calcium from the bones, resulting in weakened bones, leading to osteomalacia and fractures. And then clinical manifestations due to reproductive system includes infertility, decreased libido, low sperm counts, and decreased sexual dysfunction. Psychological changes include emotional lability, depression, personality, and behavior changes. Lastly, diagnostic studies includes history and physical examination, urine for protein albuminuria, urinalysis, ultrasound, renal ultrasonography, renal scan, CT scan, and renal biopsy. kidney biopsy may be necessary to provide a definitive diagnosis.